Right, so this is one of my success stories that I can't wait to share, all right? And I never thought that I would ever get success because of the complexity of this child, all right? So it's the SOAPIER framework. So S is your subjective information. O is the objective information. A is you making your assessment. What are the problems? And P, right, we're going to put a plan in place, okay? And I, we get on with the interventions, the plan, then the action starts. And then E, we evaluate. And then it's a regular cycle of evaluation and review, okay? Because sorting bowel and bladder problems out in individuals with complex needs is short steps to reach your goals, okay? So you've got to be in it for the long haul. Now this is lovely Edward, all right? And he has a very rare syndrome. It is so rare, but unfortunately, it affected just about every system in his body apart from his skin. All right, he had global developmental delay, hydrocephalus, which meant he had a big head and he was a bit wobbly, that somebody had to walk with him all the time, or he would lose his balance, which you could imagine trying to get him on the toilet would be a bit difficult. He was overweight. He only had one kidney. And he also had hearing loss. He had cochlear implants. And he had problems with his sight, visual defects. So there was a lot going on. And the mum was like, she just felt, I'm sure we can get there. I'm sure he's got the cognitive ability to be continent, and I really want to try and get him out of nappies. I said, right. And it was the Senko teacher, you know, who came on board. The Senko teacher is the Special Education Needs Coordinating Officer. All right, he's usually the deputy principal of a school who takes that role on to help kids that have got additional needs. And as I say, this was through I was really lucky that Continence New Zealand allowed me to do this support for the family. But he wasn't getting anywhere. They'd put in high health needs funding, they had an occupational therapist, they had a physiotherapist. They had a huge multidisciplinary team. That they were worried about losing the high health needs funding, because to keep, you know, that if there was no progress made, the funding would be taken away. And he did not, would you believe it, he did not have ORS funding. It just so happened that the teacher aide thought that Edward might be constipated. That could this be why we're not making any progress? And he's got a real fear. He cries and he doesn't want to go and sit on the toilet at all. And that he was often fatigued, poor focus. He really wasn't getting much out of school at all. And yeah, this is who you're dealing with. There's a lot that was in his team. So you could imagine how exhausted Mum was trying to navigate. Mum stayed at home, because there was appointments every single week. As I say, that I went and got information from everybody to make my assessment. And I also did the objective assessment as well. is the bowel diary, bladder diary, history, diet and fluids. So basically the teacher aide was right. He was severely constipated, and there were offensive smelling, dark, sticky, and he had that poo look on his face. Fear. And that he would have lots of like sneaky poos, soiling in his nappy, and then maybe every week he would have a huge type 2. Okay, he didn't show any signs of pain, but he knew that his mum was getting frustrated, you know, with having to clean him up all the time. And he did say to her one day, you won't get angry, will you, Mum? Because I think he obviously saw in her face that she was frustrated and upset. And this was what shocked me the most. And I thought, oh my gosh, if we don't do something about this, he's going to lose his only healthy kidney. He's going, you know, we're going to get really severe renal failure. Because he hardly weed. And, you know, his urine was dark, okay? And he was on antibiotics because high risk of urine infection. And concentrated urine. And small voids, only 50 mils, when he should be peeing out 210. And no wonder, because this was his diet. He would only drink Coke Zero and milk, lots of milk. And she tried, Mum did try, but you know, I know where she's at. You know, you can maybe say, well, the parents shouldn't be giving him this, that, and that, you know. But if that's all he'll take, it's not easy. It's not easy with these kids, and she needed a team behind her to try and change habits. So again, it was me coming in and doing slow steps to success. All right, so from the SOA, subjective, objective, and my assessment, this is the problems. And you're going to say, oh my gosh, where do we start? Where do we start? Bowels. Okay, yeah, we start. So the first thing I told everybody is back off getting him to sit on the toilet. Back off. Because that is causing him more fear and anxiety. And what is fear and anxiety doing to his bowels? Making it worse. So everybody had to back off that all behaviour is communication, and his behaviour was telling me that I have a fear of sitting on that toilet because Mr. Pooh is not my friend. Mr. Pooh is my enemy. So why are you making me do something I really cannot do yet? So this is what we kind of worked out. To be out of pull-ups and semi-independent, he would always need some support because of his balance issues. All right, that he would always need help because the hydrocephalus isn't going to go away. All right, we were going to be working on his muscle tone, but we needed to get his bowels healthy first, then his bladder, and then work on the toilet training and the environment. Okay, so back to basics. Remember one of the principles, the KISS approach. The one thing that I say to remember the plan, that who's in charge, who's the director? The parents or the caregivers, because they know they're with the child better than anybody else. If they feel something isn't right with an intervention that I've said, hey, let's do this, and if they say, nah, that's not going to work for Tom, then I'm okay with that, let's try something else, okay? So again, it's having that good, open, honest, direct communication, all right? So the action plan, and it was, as I say, it's going to take up to a year. And that most of the communication went through the SENCO teacher, the SENCO, the mother and myself, and then the SENCO then communicated it out to the other members of the family. I wanted to change him standing up with holding on to a handrail. he needs to be an active participant and see what the fruits of his labour is. He needs to be able to look. Rather than lying down, you know, that when you're babies, it's fine to lie down and they're submissive and passive and they don't see what's happening. But he was getting changed lying down, and I wanted to start. He's a big lad, he's not a baby. Okay? So these were just a few of the things that I suggested. I did my 4 E's. So we did the evacuation, we did the elimination, re-established, but we couldn't get him standing up for changing his bum because he just didn't feel safe. It's all about balance and how his body was telling him this doesn't feel safe. So that was still work in progress. But we did start to get him, and I cannot do it, because obviously we're not going to get him sitting on the toilet or anywhere. So we got him to squat like a frog with support, okay, holding on to a handle or whatever, and squatting like a frog. So remember that, squat like a frog, okay? For some, like, as I say, I can't demonstrate, obviously, because I'm just not able to squat anymore. So, all right. And looking at things he liked. Okay, there was a CBeebies video on constipation. There was Mr. P, he did engage in these things. And looking at charting, documentation, communication between home and school. And that the school, we started a very short drinking plan, where if he took 50 mils of water, he'd get 50 mils of Coke Zero. All right. And then we eventually changed that Coke Zero to lemonade popsicles. So we did things, gently, slowly, one step at a time. Okay. And we got him emptied out, and Mum became a poo expert and was starting to self-manage his laxatives by looking at what Mr. Poo looked like. She was just amazing, all right? 2 months later, we're tracking well. We're tracking well. We're having nice, happy poos. We've had no setbacks. Still in his nappy. Tummy has come right down. No longer hiding, but still won't go anywhere near the toilet. And we've managed to, again, get the medication down a bit. So we just kept that the same, and then we worked on increasing his water intake, all right? And we did try, he didn't like it really, but we did say, because kombucha's fizzy, isn't it? And kombucha's quite healthy, but he wasn't having a buying of that. No. But we did do some fun water drinking competitions, because he actually had a competitive streak and he wanted to beat his siblings. So we worked on that as well. And we did get there. We did improve his water. And I do lots of boss plans for the children. They can decide what picture that they want to put on it. I've got boss plans for daytime wetting, for bed wetting, but it's individualised to every single child that I see. So this was just a wee social story about drinking water and doing his poo, okay? That if you feel Mr. Poo coming out in your nappy, squat like a frog. Simple, okay? When you feel Mr. Poo in your nappy, tell your mum, okay? And, and every time he did something in his nappy, he gets a drink of water. And then you'll get a lemonade popsicle or a bit of Coke Zero. 4 months later, we've still got that avoidance. Remember, he's had a problem with severe constipation for many, many years. So it's going to take a long time for his elephant brain to forget, okay, that he knows that Mr. Poo has not been his friend for many years. It's going to take a long time for that positive, happy feelings to come back, that it's okay. It's okay to let Mr. Poo come out. Okay, family bought a swimming pool, and he loved, and that oh, that was just amazing, absolutely amazing, that his muscle tone improved. He was in the pool every day, and we were still improving. We were getting much bigger wets, and it was less concentrated, less smelly. So I was starting to feel great. We're getting better renal function here. And he was, as I say, we still had to keep the water drinking using rewards. All right, that we had to keep going with that. But as I say, Mum was seeing the improvement in him. And so, yeah, you know, we've got happy bowels, happy bladder. Now we can start the toilet training. And how long is that? That's about 6 months. Or 6 months, okay? And that he was starting to show signs. And yeah, we were getting there. And I think the one thing is that if for any reason, you know, and I said to Mum, don't force him. He has to want to do this. So there will be days, remember the light bulb? There will be days that for whatever reason he's not into it. Then don't fret. Don't fret. Just back off that day and try again the next day. There is down there that I did suggest that we look at a designated safe place for Mr. Pooh to come out in because he was shy. All right? And that he can have a small rug in the bedroom, a round rug with his toilet treasure bag. And whenever he felt Mr. Pooh coming, he would go to his little rug in the bedroom, toilet treasure bag, squat like a frog. All right? And that has worked for a lot of kids that I've worked with, because you can move these items slowly to the bathroom, to the toilet, to the side of the toilet, to sitting on the toilet with a pull-up on. But that could take many months, okay? But it can work, all right? And as I say, he was doing great, much better at school. And yeah, the school were just like, wow, his learning had shot through the roof. He was enjoying reading, he was walking better, he was talking more. You know, we were still not quite getting him on the toilet yet, but that's okay. All right? We were still trying to get him to change him standing up, but not quite, you know, and I think we had to bear in mind about his complex disability that he had. Okay, that we have, all behaviour is communication, we have to go at his pace. But we were just seeing such huge gains. And as I say, Mum is feeling really confident. She eventually got the rug in the toilet treasure bag to the toilet. And he's happy sitting on the toilet at home, after 8 months, with his pull-up on for short periods. And that we got the school ready, so that he was definitely, when he was going to start sitting on the toilet school, that he had an over-the-toilet frame and a footstool, so that he was in the proper squatty potty position. And that because he was, his whole body, you know, that he felt stronger and had better balance, we were able to change him standing up as well. 10 months later, we've just about cracked it. All right, that we've got him into a good bowel routine. So all you think, oh, we've just worked on the bowels, we've actually still got the wheeze to work on, you know? But the bowels is a lot easier than the wheeze, because you generally go how many times a day? Once or twice a day, okay? Up to 3 times, okay? We're reducing the laxatives, we're keeping the fluids up, and Mum had this chart that, you know, it was numbered 1 to 10, and whether he had a result or not, when he sat on the toilet, he would cross out a number. When he got to 10, he went to the $2 shop and got a toy. So it was rewarding the effort, not just the result. Okay, that was really important. 12 months later, no more constipation, healthy urine output, better water intake, and that he's starting now to become aware of the we, because his bowel has shrunk and the bladder has got room to work properly. All right? And Mum was really like, felt that it wasn't going to be far before he would be able to be continent, ditch the pull-ups, but be continent with support and prompts from a teacher aide. But imagine that, being able to get a young lad with very complex disabilities out of his pull-ups. Going to talk about some of the clients that I've supported that sort of stand out, and hopefully that will give you some tips and tricks. So this was one that, again, was quite hard. So this is Tom, and he's a 15-year-old autistic lad. The mum talked about the restrictions that Tom put on the whole family because of his toileting troubles, that they couldn't go away from the house for more than 4 hours because he just wouldn't actually go anywhere else apart from his own toilet to wee. And even then, he would only stand to wee. And when he stands to wee, he always had an iPad in his hand as sort of safety, security. Even if it wasn't on, it had to be in his hand. There had to be somebody there to make sure he pointed the penis in the right place, or he would pee all over the floor. He'd pee everywhere. All right? And yes, they had carer support, but Tom did not like anybody else attending to his toileting needs apart from his mum and dad. And, you know, he did have high anxiety. They struggled to go on holiday. They tried continence products, but he didn't like them. He would take them off and he would smear on the floor and the walls if the parents didn't get to him quick enough to clean him up. They got a routine with his poop, which was kind of manageable. He had high anxiety. He liked to be in a quiet place to eliminate. And they eventually got a routine where he would go to the laundry room, which was at the far end of the house. And he would defecate in a specific position. So he would do that every day after lunchtime in his undies. Okay? Mum really just wanted, or the parents wanted a bit more freedom, that they didn't have to be there every 4 hours to attend to his toileting needs. And that as a family, they were maybe, you know, to try and get out for longer periods without him getting stressed and anxious and wanting to come home and, you know, to use the toilet. So I, you know, as I say, it didn't sound like he was constipated, but I suggested to Mum, do the sweet corn test, rule out constipation, see if you can. Okay, so again, these were just suggestions. All right, and I only had that one-off appointment. But I said, secure his iPad, that you can fit it in, you know, somewhere in the toilet area, so that he can be watching his iPad. He loved music, absolutely loved music. So they, you know, have that there so that he would have both hands free so that he would hopefully get the hang of holding his penis to wee in the toilet. I also suggested just starting Tom sitting for 10 seconds on the toilet, just, you know, when he was in fairly calm state, with his iPad, sitting on the toilet, 10 seconds, an M&M, immediate reward. And he did like lollies and chocolate and things like that. We looked at, as I say, you get these soft toilet seats that actually has a bit of a guard at the front to stop the wee sort of going everywhere. I said, you know, maybe try that. And I said, you know, and again, they'd taken a long time to get him having a toilet routine to empty his bowels every lunchtime. But I said, let's see if you could change that time so that it's after breakfast every time. Okay? Add in some Metamucil. Okay, let's see if that helps to plump up his bowels so it's not as messy and he has a good volume poo. So, you know, I just suggested as a gradual change, you know, look at the breakfast so that you could maybe go out the whole day. Why don't you, when you're at home, you know, just get him to pee in a cup. Just get him to pee in a cup, all right? And then that can gradually go where he might just pee when they're out and about. Obstacles to success. All right, the first thing is obviously, you know, holding behaviour. And holding behaviour is very common in individuals, particularly that have got intellectual impairment, cognitive issues, where they just get too wrapped up in what they are doing. All right, and they've got such a busy brain that they cannot decipher, you know, that there's too many messages going on, and they're not getting a strong enough message from their bottom to say it's time to go and empty. Toilet fears. And I'm going to talk to you about, oh God, it's really bad out there now. Toilet fears, okay? And I'm going to talk to you about a child who had extreme sensory issues, high anxiety disorder. Then we've got neuromuscular, neurogenic impairment. I've had quite a few kids that I've supported with muscular dystrophy, myotonic dystrophy, and they have very low muscle tone. You know, sensory sensitivities, I'm going to give you some examples of these. And yeah, it's difficult to change habits, set behaviours and habits. A lot of individuals with additional needs don't like change, don't like that, and it can cause problems. We've already heard about restrictive diets in Edward, and again, it is just not easy at all. We also have the seasonal impact of toileting. Okay, and yeah, I had one lad, he was doing fine, and then yeah, he started holding on, getting constipated, having wetting, and it was basically the toilet area was like a fridge. It was cold, and he just didn't want to go in, didn't want to do it. I've talked a lot about, you know, giving rewards, you know, M&Ms, sticker charts, all of that sort of thing. But this was something that a paediatric occupational therapist discussed with me, is that you know, yes, we could give rewards, and they'll do what you want. You know, these children or these adults will do what you want them to do. But their nervous system is still telling them, this doesn't feel right. I'm scared. It's just not right. And that has seen, that she said that there is studies showing that if we keep pushing, you know, these individuals to do something that their nervous system is telling them is not right, it can cause trauma in the brain called chronic post-traumatic stress disorder. So we do have to be aware of that. And I kind of like to think that they can't yet rather than won't. We just need to look at a different way and accommodate their needs differently. And I'm just going to briefly go through, because you'll be thinking, oh my gosh, I didn't know we had that many senses. But we do. I'm just going to briefly hit on each one. All right, so Amy. And this is one that I didn't fix. All right, you don't win them all. And this was one, she was always, even when she was first born, she was a highly sensitive baby. A very poor sleeper, would only sleep with her mum beside her. And she would only eat bland, easy to take food. And she was still breastfeeding at 5 years of age. Because of her high levels of anxiety. That sucking helped her calm down and self-regulate. Okay? She struggled with noise. She hated the toilet flushing. She had severe separation anxiety. They tried taking her to the kindy, but she would have huge meltdowns. She couldn't go to the supermarket. She had huge meltdowns. And the parents had tried every which way, every strategy under the sun, to try and get her to toilet train, to sit on the toilet. And nothing worked. And she would scream and get a really huge meltdowns. They put her in undies, and she would go, she would go and get a nappy and hide in her bedroom to poop. But when I investigated a bit further, she hardly ever weed. In the undies, she held on all day, or until she could get her nappy on. And it turned out with the bowels, she was only having them once or twice a week. There were large logs, dark, sticky, and really offensive smelling. So again, I just said to Mum, back off on the undie, put her back in pull-ups. There's just no point getting her to be that is not good for her bladder. Pop her back into the pull-ups. We'll get her constipation treated. We'll look at trying to reduce the amount of dairy in her diet, which was constipating. And I kind of like during the day is dilute the milk 50-50, 50 milk, 50 water. And she did have a real fear. And she was able to articulate that she felt that she was losing part of her body. That, pooing, she really did not like this. And she perceived it as a very dangerous situation. As I say, we started the laxative treatment. The parents backed off. We got her back to having, healthy bowels and healthy voiding, but all in her pull-up. And as I say, I said we really do need to refer on to a paediatric occupational therapist to really look at a sensory diet, as they call it. All areas, not just to do with her toileting. It was in all the areas that she was trying to navigate. So that you know, was one that I just never, because it was just so, she was just so like a prickly hedgehog all the time, just high wired, just ready to fly off at the least little thing. So it was going to be very, very, very slow steps to success. So, toileting and the senses. That a person can be either hyper-responsive or be hypo-responsive. Okay, so they can react in a abnormally out of the control situation, or very little awareness at all. So this is just sort of for the tactile sense. All right, they might not like sitting on the toilet seat, so get a fluffy toilet seat cover. They dislike the splashback on their bottom, so put toilet paper in the pan first, so that they don't get that splashback. Feeling exposed sitting on the toilet with their bare bottom. I had a lad, I just put like a weighted blanket, a weighted lap belt over him. Getting wee and poo on their hands. And that's quite a common one. And yeah, I had a 25-year-old lad with Down syndrome. And I'd known him probably since he was 9 years of age. And Mum was still struggling that he was 25 years of age and he was still having issues with soiling in his undies. And yes, Metamucil helped, okay? But because he was having quite messy poos, we got him on some decent laxatives. And I told him, why don't you use disposable gloves to wipe your bum? He didn't. It turned out he did not like wiping his bum. I thought, you try that and see if that helps reduce the soiling in his undies. And it did. Just a few things like that. And Mum was like, wow, this is brilliant. You get the opposite, the hyposensitivity. And that's where less is more, because they're touching everything. They enjoy, they might enjoy the feeling of wee and poo. They might be pulling all the toilet paper. They might be flushing the toilet. All of these sort of things, because they need more stimulation. But for hypersensitive, you know, less is more. Keep things, you know, out of the way of the child. A lap pad, make sure that the water's never too hot, because they'll be playing with the water. You tape a line, you know, and kind of say, this is how much toilet paper you're meant to use, not the whole toilet roll, okay? Auditory, okay? The echo of the toilets, the flushing, you know, can actually, you know, put a lot of individuals off, especially public toilets, school toilets, okay? So again, use things that's going to absorb the echo, absorb the sound. And obviously in some places now they have hand dryers, but they also have paper towels. Visual. So again, soft lighting, remove things, look at the, you know, does the mirror need covered? You get light sensitive glasses and make it a softer lighting. You know, visual, again, they might need bright lights. They might need posters on the wall, sensory toys that light up. All right, gustatory, which is the taste, which doesn't kind of come into it with toileting, but in order to keep them calm, it's quite good for them to chew on things. You know, a chewable necklace, a chewable bracelet, things that they can chew on to help regulate their autonomic nervous system and keep them in the blue zone. Okay? Olfactory, smell. Okay? And as I say, I do struggle with long drop toilets. And you know, I think most of us do struggle with smells in public toilets, don't we? But you know, these are really good. It's just these little scented stickers that they scratch. So just as easy as that. All right. That would maybe just help. You also get these Scentsy toys that they can have a cuddly toy that actually's got a nice lavender smell. That could be something that might just help to calm if they're hypersensitive in that way. Vestibular. If the vestibular, they've poor balance, and they might have a fear of falling into the toilet. So again, we need to look at equipment and adaptations that will help. And as I say, I mentioned about the 4-year-old who had a fear of using the toilet seat because the toilet seat in his home was all wobbly and he fell off, and then he didn't want to use the toilet seat again. And sometimes with these toilet inserts, they're not secure. Okay, and kids do feel a bit, oh, I'm not sure. So you get these dual toilet seats that's built in, and you get them at Bunnings. Okay, they're brilliant. And so you have just a normal toilet seat, you put that down, and the small toilet seat is all together, so it's far more secure. I love these grab rails, because these grab rails, you can put them, they can be moved. They can be moved to suit for children, you know, that have problems with the vestibular sense. The toilet roll holder might be too far away from the toilet, and they're scared to reach over to get it. So get a self-standing one that can be quite close to the child while they're sitting on the toilet. So just a few little things will actually help. Proprioception. All right, they need movement. Okay, they don't like to sit still. So again, you know, we might need to look at, and I used to do it with some kids, it's just they're sitting on the toilet and they've got a ball and they can just be rocking back and forward, get another ball, rocking back and forward, and they're constantly moving, but they're doing rocking and popping, they're doing that movement to try and help with emptying their bowels. As I say, we've got the fluffy, I love that fluffy toilet seat cover. You know, you may just need to, because they don't like to sit still, is again, you know, having timers, sensory timers, digital timers, to try, you know, that this is how long you've got to sit for. Toilet supports at the back. I remember a parent just had like a swim noodle that he cut that just made the child feel a bit safer while sitting on the toilet. Okay, so this is the 8th sense, which is interoception. And this is really, again, it's just come in the last few years. And Kelly Mailer is an occupational therapist. She's done lots of YouTube videos, and it's still work in progress, really. There's still a lot of things that we don't know. But really, what is interoception? What is it in relation to toileting? And basically, interoception is from the inside out. It's our internal sense of understanding what our body's telling us. Okay, so when we're hungry, we go and get something to eat. When we're thirsty, we go and get something to drink. Okay, when we feel that need to go to the toilet, we go to the toilet. But some children may have what we call low interoceptive awareness and may not get the hang of the toilet because they're not responding to these strong messages. Okay, and some people may have an elevated response to these sensations. Okay, so some it may be low and they may not know when they need to go to the toilet and have accidents, and others it may be that they're expressing it through severe anxiety and meltdowns. So these are, and how do we manage that? All right, but one of the things that and there's a lot of information, but really is engaging the blue zone more. Things that we can do to help calm the child down, calm the person down. Deep breathing, mindfulness practice, relaxation, yoga. And certainly for kids, there's a great YouTube called Cosmic Yoga. And it is absolutely brilliant. But there's still a lot of things that we don't know. But it certainly, for a lot of kids, they actually haven't got that interoceptive awareness to know that they need to go to the toilet. And that's where they are going to need external reminders and external prompts. Then we've got neuroceptive. And this is research that Stephen Porges has done about it's a safe and sound musical therapy. It's to help children and adults calm their nervous system. And that could be the reason, why some have huge anxiety around toileting. Okay. The Y position. Whenever I see children in the clinic and they're constantly sitting in this Y position, I will say, can you nip that in the bud? Because that can affect their pelvic floor, and that can affect their core strength and their bowels particularly. Retained primitive reflexes. And we've got 7 primitive reflexes. And they're important in the early stages of life. But what they found, in children that have sensory processing disorder or autism, is that sometimes these primitive reflexes don't switch off. They retain their primitive reflexes, and that they may, as a result, experience bowel and bladder dysfunction. And who's at risk? Who's at risk, of having retained primitive reflexes? The most common one is if children are born via C-section. It's actually going down through the birth canal that will often cause these primitive reflexes to be switched off. If they're born via trauma, forceps, lack of tummy time, and 80% of children with autism and other neurodevelopmental problems have retained primitive reflexes. So these are things that would need to be assessed for as well. And often a good person is a paediatric occupational therapist or a chiropractor or an osteopath or a neurodevelopmental therapist that would be able to assess as to whether this could be a reason for issues, you know, and delays toilet training. So this is a girl that I helped last year. She's 8 years of age and she was adopted as a baby. And she had all the features of fetal alcohol spectrum disorder. But because there was no maternal confirmation that she was just at risk, she didn't have the definitive diagnosis. But she had constant wetting and soiling. She had severe blisters on her vagina, vulvovaginitis. She had long-standing history of constipation, anal tears and rectal bleeding. A significant pee and poo withholding behaviour and very poor fluid and dietary intake. That she had difficulty actually swallowing water, and she was functioning probably at a 3 or 4 year old level. She had severe sensory sensitivities to noise, tactile, and probably interoception. So yes, you know, I did my full SOAPIER framework, getting the full assessment, but I also said to Mum, has anybody, you know, investigated the thing that she struggles to swallow water? You know, does she actually need investigation, a video fluoroscopy or something like that? But in the meantime, I said, how do we get her water intake up? So I suggested some food thickener, because she would take these apple squeezy things, you know, that was in, she would take pureed fluid like that. So I thought, well, we just need to give her more of that pureed fluid, but make it like, you know, just with water. We got, you know, we had to treat the constipation. Again, we did the 4 E's model. We got the multidisciplinary team together, occupational therapist, speech and language, SENCO, and the social worker. We looked at, as I say, she would void maybe twice a day if you were lucky. She had dysuria, which was painful pee, and her urine was a very dark amber. So she had really shocking renal or urinary function. Her bowels, yeah, type 1, 2, she called them spiky poos. She had tummy pain. She got really upset when she was about to pass a motion. And really she just had pureed food. I did a BOSS plan. We had to do the toilet gym to get the bowels back and trim. We looked at earmuffs because she was sensitive of the noise in the bathroom. We worked on some nice deep breathing exercises, and she loved sloths, so she had her cuddly sloth toy in the bathroom, and the toilet treasure bag. We kept the steps short. We got a drinking plan going, and we did add flavoured mineral drops as well as the food thickener. And 6 months later, she had a nice healthy bowel routine. There was less wetting. Her urine wasn't concentrated. She had a high health needs funding in place at school and had a teacher aide to help her. And she was starting to self-initiate going to the toilet. Really, it was just monthly updates and reviews to kind of keep her on track. But she was certainly focusing a lot better in school, and just by getting her fluid intake increased, we were able to get things sorted with her bowels and bladder. Now, that is me